Thank you for attending our Prostate School New Diagnosis seminar. The aims of this session are to outline the various treatment options which you may be suitable for. These include surgical removal of the prostate, otherwise known as RALP, hormone treatment and radiotherapy, active surveillance, focal treatments and low dose rate brachytherapy. It is important to mention that you may not be suitable for all of these treatments depending upon your disease. The aim of this is to just give you an overview of the different options which you may be suitable for. You can also navigate this video using the chapters on the bar below. You will have the opportunity to discuss these options with your consultant and your clinical nurse specialist at your next appointment. You will also be given the contact details of a clinical nurse specialist who will be your key worker and help you decide upon your treatment. I'm now going to talk about the option of active surveillance for prostate cancer. So, active surveillance is carefully watching a prostate cancer rather than treating it. Treatment can have more risks than watching in less aggressive prostate cancers. Two questions are asked during active surveillance. Number one, how much cancer is present and do the MRI and biopsy results match? In addition, has anything got worse over time? Only the less aggressive types of prostate cancer suit active surveillance. Understanding the prostate cancer stage. So all cancers are described by two main terms, stage and grade. Stage tells us how much the cancer has grown since starting. Active surveillance is only for prostate cancers that are within the prostate. These are called stage 1 and stage 2, or T1 and T2, as seen on the picture. Now to understand prostate cancer grade. So grade is the second term we use to describe cancer. Prostate cancer types are given a number from 3 to 5. 3 is the mildest, 4 the middle, and 5 the most aggressive. Prostate tumours are often a mix of these types. This tells us the Gleason score, so it may be 3 plus 4, 4 plus 3, 3 plus 3. Gleason was a pathologist who devised the scale. The most common type of cell seen is recorded first, and the second most common type afterwards. For example, a tumour that is mostly type 3, which is the least aggressive, with some type 4, which is the middle kind, is called 3 plus 4. A tumour that is mostly the more aggressive type, type 5, with some of the middle type, type 4, is called Gleason 5 plus 4. A tumour that is only the least aggressive type, type 3, will be called Gleason 3 plus 3. So which prostate cancer suits surveillance? Active surveillance can suit prostate cancers such as Gleason 3 plus 3 and sometimes 3 plus 4, which are the least aggressive types. It is a decision to be made by the patient and the doctor together. They will also consider some other information in making that decision, such as the PSA level, the MRI scan of the prostate, and whether there is a strong family history of prostate cancer.
Different hospitals may vary in their timetable for active surveillance tests. In general, a PSA blood test is done every few months, a repeat MRI scan after a year, and a further prostate biopsy if the scan or blood test look more suspicious than before. In the least aggressive cancers, we may space the scans out more over time. And in the least aggressive cancers, we may eventually just need to check the PSA blood test.
In some men, we suspect more cancer may be present than was found in the original biopsy. These men may have another biopsy earlier than a year. You can see an image there on the right. Some men on active surveillance may end up choosing treatment for various reasons. Either their tumour is growing, or another biopsy has revealed a higher grade or more aggressive tumour, or their preference for dealing with the cancer simply changes. So you might be wondering, will you need treatment in the future? So some men on surveillance are more likely to need treatment in due course. This is generally if their cancer is clearly seen on their MRI scan, or if they have Gleason 3+4 prostate cancer rather than 3+3. Some men choose surveillance at first to delay potential treatment effects until later in life, including problems with erections or problems passing urine or incontinence. So active surveillance is a way to avoid the risks of treatment in prostate cancer. Some men will have further biopsies during surveillance. Modern biopsies are low risk, though can cause a urine infection in 1 to 2% of men, urine retention problems, including emptying the bladder, in around 1 to 2% of men, and blood in the urine or semen. This is likely, but almost always mild. The risk that a suitable man having active surveillance using modern tests misses the chance to successfully treat his cancer is extremely low. So in summary, active surveillance is an option in the least aggressive prostate cancers. In these cases, the risks from treatment may be more than the risks from the cancer itself. Surveillance involves repeating the blood tests and the prostate MRI, and sometimes further biopsies. It may be a long-term option for some men or want to delay treatment side effects until later in life. I'm now going to talk about robotic prostatectomy. The aim of this is to introduce you to robotic treatment, prepare for surgery, understand what to expect afterwards, explain some of the side effects of surgery, and what happens if the cancer returns. So what is robotic surgery? Robotic surgery is minimally invasive keyhole surgery. The main advantages to the patient are reduced pain and blood loss, faster recovery, and reduced complications. From a surgeon's point of view, the advantages are improved magnification and surgical precision, and reduced surgical fatigue. As you can see on the right, this was how we used to do the surgery with a long incision, and now with the Da Vinci robot, there are generally 5 to 6 small incisions. So what is robotic surgery? In the operating theatre, there is a patient cart containing robotic arms. There is a console used by the surgeon to control the robotic arms, and at the bedside will be an anaesthetist, an assistant surgeon, and the nurse. So the consultant surgeon is in the same room but sat at the console operating the robotic arms. The average operating time is around 2 to 3 hours. This excludes the initial anaesthetic and waking up from surgery, so the whole process takes around 3 to 4 hours. So not all men are suitable for robotic surgery. Some men who have major heart or lung problems, they may not be suitable, as it can increase the risk of heart attack, stroke, and pneumonia. Men with uncontrolled diabetes are at risk of post-operative infection and poor wound healing. Men who've had previous major abdominal surgery may not be suitable, as there may be adhesions, and some men may need to have instead open surgery. In addition, men who are severely obese, this can cause difficulty with breathing during the anaesthetic and difficult technical surgery. And from a cancer point of view, some men where the tumour is too advanced and cannot be safely removed without leaving some cancer behind, then surgery is not their best option. So the prostate is removed with its attachments, including the vas deferens and the seminal vesicles, which are responsible for ejaculation fluids. The nerves, if required, depending upon where the cancer is, that are responsible for erections. The bladder is then attached to the urethra or water pipe with a catheter left in place to allow for healing. In some men, the lymph nodes are also removed in the pelvis, as the pelvic lymph nodes are the first sites of cancer to spread. These are only removed if there's a high risk of spread and will be discussed with you prior to your operation. So at UCLH, it is tailored surgery, so all men's cases go through what's called a surgical planning meeting to discuss whether the nerves are going to be spared for the erections, whether there needs to be any lymph node removal. So to make a plan of your individualised surgery, the things that are considered are the tumour grade and the size and the Gleason score. Urinary incontinence is a side effect from surgery, and some men who have a shorter urethral length, this can cause incontinence that takes longer to improve. Most men will need to wear pads after surgery. At 3 months, about 70 to 80% are wearing one pad or less per 24 hours.
At the surgical planning meeting, the doctors will decide whether they will be able to spare the nerves responsible for erections. These are located at around 5 and 7 o'clock around your prostate. The more larger tumours or cancers are more likely to invade the nerves. Things that can affect whether the erections come back after the surgery are if you have normal erections before the surgery and whether the nerves are able to be spared. This will be dependent upon where the cancer is, as you can see from the diagram on the right. In addition, younger men below the age of 60 years are more likely for their erections to return. If neither nerves can be saved, then there is only a 0 to 20% chance of getting erections using medication following the procedure. If one side is spared, the chance is around 30 to 40%, and if both are spared, the chance is around 70 to 80% with medication by around 18 months to 2 years.
Most patients stay in hospital for one night. They're able to eat and drink and walk around before being discharged. Pain is usually only mild or moderate, and most men only require paracetamol and or ibuprofen. The catheter is usually left in for around 14 days. Some men can get what's called a bladder spasm, where they have a strong sensation to void occasionally. However, it's usually tolerated well. Before you go home, you will be shown how to manage the catheter. You will be shown how to administer an injection to stop blood clots. This will be once a day for the first 28 days. You'll be encouraged to do some walking daily and to not sit for long periods of time. You must avoid any heavy lifting or anything strenuous for 6 weeks, including bike riding. One of the nurse specialists will come and see you on the ward before you're discharged, and we will call you a week before your operation and a week after your operation to see how you're getting on. With regards to side effects, so there can be catheter discomfort and discomfort in the penis. Some men get shoulder tip pain as the abdomen is blown up using gas during the operation to allow for the surgeon to have a better view. This is removed after the operation, but you can get referred shoulder pain, abdominal bloating, erectile dysfunction, and you will have an absence of ejaculatory fluid, including semen, so you will be infertile following this. If any men want to save their sperm, they should let us know and we can arrange that. Occasional side effects are large blood loss. This rarely leads to infusion, with about a 1 in 800 risk. Some men can get a urinary tract infection. For some men, if the PSA does not drop to undetectable levels, then extra treatment may be required, which is likely to be radiotherapy and hormone treatment. Very rare side effects include a urine leak, around 5 in 100 cases, requiring the catheter to be kept in for longer. Urinary incontinence is common after surgery, and around 3% of men will require further surgery to correct this after a prostatectomy. Very rarely there can be injury to other organs, and this may require repair during the surgery. In addition, a rare side effect is a hernia through the previous incision, and that can be avoided largely by not doing any heavy lifting in the first weeks after surgery.
Rare side effects can also include requirements to be cared for in intensive care by a chest infection, a deep vein thrombosis or a pulmonary embolus or clot, a heart attack. Death is exceptionally rare in less than 1 in 3,000 men. Some men may need the operation converting to open surgery, which is around 1 in 300 men at UCLH. This may be due to extensive prior abdominal surgery or excessive bleeding. Rectal injury is very rare, around 1 in 500, and most can be repaired surgically, with a stoma only rarely being needed to be created.
So following up after surgery, the catheter is removed here at UCLH around 2 weeks following the surgery. You will be taught how to commence pelvic floor exercises to help with continence. With regards to follow-up, the first follow-up will be around 4 weeks from the operation to speak to one of the consultants, and the results of the surgery will be discussed with you, where the whole of the prostate has been removed and analysed in the lab. Any concerns about continence and erectile dysfunction can be discussed, and then you'll go on to have a 3-month PSA check for the first year. For some men, their PSA comes back up after surgery. Most of this will be within the first 2 years, but can occur later. The risk of this is higher if the cancer grade is higher or if it was more advanced before the surgery. This can be safely observed until it reaches a certain level, usually 0.1 or 0.2, at which case a PET scan will likely be arranged, and sometimes radiotherapy is given to where the prostate was, just to kill off any leftover microscopic cancer cells. The aim in that case is still to cure, and hormone treatment may be given as well.
Hello and welcome to the talk on hormone and radiotherapy treatment for prostate cancer. The aim of this session is to give you an introduction of what radiotherapy is for prostate cancer, an understanding of the treatment pathway, an understanding of the potential side effects of both hormones and radiotherapy. Radiotherapy is the use of targeted high-energy X-rays to treat cancer. The aim of this treatment is to cure you of the disease, usually given by X-rays entering the body from the outside in, but can also be given using a radioactive source which is placed inside the prostate, known as brachytherapy. This will be discussed in a separate presentation. There are various lengths of courses for treating prostate cancer. It does usually involve daily visits to an outpatient radiotherapy department of between 4 to 7.5 weeks. These visits will be Monday to Friday. We don't treat on weekends or bank holidays. If your treatment course falls over this period, usually the treatment would be added to the end of the course, therefore slightly extending the length of time. The number of treatments you require, the dose of radiotherapy and the type of radiotherapy will be tailored to your individual case, and this will be discussed with your consultant. The treatment pathway, this is just a brief overview. Generally, you would have an outpatient appointment with a consultant oncologist or a member of their team. They would discuss the pros and cons of radiotherapy and the potential success rate. You would then sign a consent form. You would be given a prescription for some hormone treatment, usually tablets initially, and then changing to injections. We would monitor your PSA and the side effects of the hormones. You would then have an appointment with the radiotherapy department for a planning CT scan. This is not a diagnostic scan. They are purely looking at your anatomy to make a blueprint for delivering the radiotherapy. You would then start your radiotherapy treatment, usually 2 to 3 weeks after the CT, and this could be carried out at your local radiotherapy centre. Following completion of your radiotherapy treatment, you would be monitored using your PSA blood test, and obviously we would review any side effects and symptoms that you may receive from having this treatment. At the CT planning scan, they make an individualised plan. You would have tattoo markers placed on the outside of your skin, as demonstrated in these pictures below. This is to ensure accuracy each time you attend your daily visits. A team of physicists would then make an individual treatment plan. This would ensure optimal dose to the targeted area, which is your prostate or the prostate bed, and this minimises the dose to normal healthy tissue with an aim to reducing short and long-term side effects. The radiotherapy plan. This image shows the yellow is your full bladder, the brown is your empty rectum, and the red is the targeted area where the radiotherapy would be delivered. The idea is to ensure that the bladder and the rectum are outside of the red area. We achieve this by ensuring your bladder is full when you attend treatment and your rectum is empty. This will be discussed in more detail when you attend your radiotherapy seminar prior to starting treatment. The treatment process. The actual treatment will only take about 15 minutes. However, you will be in the department for up to 2 hours. Once you're in position, images will be taken to confirm that you are in the correct position. Some days, small adjustments may need to be made, and you will feel the couch moving up and down as they reposition you. Once adjustments have been made, the treatment will start. Here is a short video that shows you a patient attending the radiotherapy department.
So the treatment session lasts 15 minutes, but the actual radiation dose that you receive will be about 2 or 3 minutes.
All you need to do is just stay nice and still and breathe away normally.
You won't feel anything, but you will know radiation is being delivered by a beeping sound that comes from the machine. You are being watched on a camera, so if you need to get the attention of the radiographers, give them a wave.
I was really worried about the actual treatment. Is it going to hurt me? What will I feel? You're laying there and the machine starts turning and making a noise. You know, you just don't feel a thing. And you just think after the first session, what was I worried about?
This picture shows a body laying on the radiotherapy couch. The yellow beam is the radiotherapy shining through the body. Obviously you won't see this beam in real life as radiotherapy is invisible, but it's just to give you an idea of how the radiotherapy passes through your body. This beam moves in a rotation all the way around, ensuring that you're covered in all directions. We have a radiotherapy review team. You will be reviewed during the course of treatment. You will be advised which days of the week this will be and how often during your course of treatment you will be reviewed. You also have access to your clinical nurse specialist, whose contact details you will be given, and is there to also help manage any side effects or concerns you have during treatment. During the course of treatment, if you do notice any side effects or if you are struggling with any aspects of your treatment, it's really important you do inform either your review team, the radiographers on the machine you're attending, or contact your clinical nurse specialist. So what are the side effects? The potential side effects of radiotherapy for prostate cancer can be divided into acute early side effects. These happen during treatment or a short time after, and then late side effects which may occur many months or even years after treatment. The short-term side effects can often be a change in your waterwork, so an increased frequency to pass urine, sometimes difficult or painful urination. You can sometimes experience some blood in the urine, occasional urinary leakage. You can get some abdominal cramping, diarrhea, painful bowel movement, sometimes rectal bleeding, and tiredness, fatigue. The aim of the review team and your clinical nurse specialist is to help minimise these side effects, but also to address them should you encounter any of them. The long-term side effects of radiotherapy again can affect your waterworks. Your urinary flow can become weak. You can have a feeling that your bladder isn't emptying properly. You can have increased weeing overnight. You can have a change in your bowel habits. This isn't incontinence, it's usually if you normally go once a day, you might find you go twice a day, and you might find you need to go more urgently. It can affect your erectile function. This is the ability to get an erection. This is not only the radiotherapy but also the hormone treatment, which reduces your body's testosterone level, which gives you the libido. You can also experience lymphedema. This is, however, very rare. Lymphedema is swelling of the lower limbs, usually the ankles, legs, sometimes the testicles. You can get some discomfort in the hip and bone area. Again, this is very rare. This is because the radiotherapy passes through the pelvis. The risk of a secondary cancer in the long term, again, very, very rare. It's the reason we ensure that you have a full bladder and an empty rectum, as we're trying to reduce the risk of you developing abnormal cells within your bladder and your rectum. You will, however, be closely monitored for any side effects or potential concerns, which you would then be referred on to the necessary team. The follow-up after radiotherapy, you will have a clinic appointment to ensure the side effects from treatment are improving and have settled. If you do have any issues following treatment, these can be addressed. The main way we monitor your success from the treatment is with your PSA blood test. This will be done 3 monthly in the first year, and as time goes on this will extend to 3 monthly, 6 monthly, 12 monthly, and then discharge. While you're having radiotherapy, alongside the treatment we also give you some hormone treatment. This helps to reduce the size of the prostate and reduce the chance of the prostate cancer spreading or recurring in the long term. Prior to radiotherapy, you will start your hormone treatment usually 3 months before the radiotherapy. You will continue the hormones during radiotherapy and for a period of time after radiotherapy. The length of time that you'll be on your hormones will vary from 6 to 9 months to 2 to 3 years. Again, this will be discussed with your consultant when you attend your initial appointment. The types of hormones we use can either be bicalutamide, which is a tablet, or a hormone injection. The tablet blocks the testosterone, so your body still produces it. The injection stops the production of testosterone. Hormone treatment, however, does have some side effects. Testosterone is the primary male hormone. If we remove the hormone, then this can give you some side effects. You can have a reduction in body hair growth, muscle mass, sexual desire, your libido, and the ability to get an erection. When you do stop the hormones, the testosterone will recover. The rate at which it recovers will depend. This is quite individual and will be assessed and monitored when you have completed your treatment. Although most men may experience only a few of these symptoms, the list of potential side effects of testosterone loss can include hot flushes, fatigue, loss of bone density, decreased sexual desire, an increased risk of osteoporosis, which gives you a risk of bone fracture, and some swelling in the breast and chest area, known as gynecomastia. All of these side effects will be discussed in detail with you and your clinical nurse specialist or your consultant prior to commencing treatment. We do have ways of managing the side effects of hormone treatment: good diet, plenty of exercise. There are some herbal remedies that can help with some of the side effects of hot flushes, acupuncture, and there are some conventional supportive medications that can also be used. All this will be discussed at length if you decide to have hormones and radiotherapy.
I'm now going to talk about focal therapy as an option for treating prostate cancer. So what is focal therapy? Focal therapy is a day case procedure under general anaesthetic. Ultrasound during the procedure shows us the prostate and lets us target the tumour. Focal therapy is a newer treatment and long-term results for cancer control are not yet available. If cancer returns, focal therapy may be repeated or another prostate cancer treatment used. So when does prostate cancer suit focal therapy? Focal therapy is suitable for intermediate risk prostate cancer. The part of the prostate to be treated must be confirmed by the MRI scan and a prostate biopsy. This may require a further MRI scan and sometimes a targeted biopsy. The rest of the prostate should either be free of cancer or have only mild cancer which wouldn't be treated anyway. So how is focal therapy carried out? It is a day case procedure under general anaesthetic which takes about 2 hours. There are 2 types of treatment. HIFU, which is high intensity focused ultrasound, heats the targeted tumour, or alternatively cryotherapy freezes it, and the one that we choose depends where the cancer is in the prostate. A catheter, which is a small tube through the penis into the bladder, is placed in for around a week. Focal therapy has lower side effects than surgery or radiotherapy. 99% of men are continent after focal treatment. With regards to erections, around 2/3 of men have erections as good as before treatment. About 1/3 of men do get good erections but may need tablets to do so. About 1 man in 20 will have erection problems that are not treated by tablets. Around 1 in 12 men may get a urine infection, and very rarely around 1 in 900 men may get a fistula, which is an abnormal connection between the prostate and the back passage. This is very rare, however is a serious side effect and can need bowel surgery to correct. Focal therapy is a newer treatment, so we do not yet know how effective it is in the long term. We now have good results up to 5 years after treatment, our first 1,000 men to reach this point. At 5 years, around 10% of men, so 1 in 10, needed a different prostate cancer treatment, and around 30% of men had a second focal treatment, either because the cancer had returned to the treated area or because a cancer had arisen in a different part of the prostate. If the prostate cancer does return, if this is less aggressive, we could have further focal therapy or surveillance. If more aggressive cancers are found, then you may need surgery to remove the prostate, which is harder than without focal treatment beforehand, and cancer control may be less effective with side effects looking to be higher, or radiotherapy. Some men who are older choose hormone drug treatment instead. So in summary, focal therapy is a newer treatment with lower side effects. It treats only the part of the prostate containing the cancer. We understand its success 5 years after treatment, but longer term results are not yet known, and focal therapy can be repeated if needed.
Low dose rate brachytherapy. Low dose rate brachytherapy is used to treat some prostate cancers which have a lower risk of spread. Not all patients are suitable for this type of treatment. Patients who might be suitable are some of those with a Gleason grade 3+3 and some patients with a Gleason grade 3+4, and also a PSA blood test level of less than 10. It is not usually suitable if the cancer is on one side of the prostate, is on both sides of the prostate, or if you have severe problems passing water, as it can make your urine problems much worse. If you are having low-dose rate brachytherapy, the procedure is carried out at Bart's Hospital. It is done as a day case and you will have a general anaesthetic. When you are asleep, a catheter is placed to drain the urine from your bladder. Then an ultrasound probe is put inside the back passage to take pictures of the prostate and to help guide the doctors to put the seeds into the prostate. Thin needles are put through the area between the testicles and the back passage, called the perineum. Radioactive seeds are then put through these needles into the prostate. We usually use between 50 and 80 seeds for each patient. Once this is done, the needles are taken out and the seeds are left behind. The treatment usually takes between 90 minutes and 2 hours. This picture shows how the seeds are placed into the prostate through the special needles. Once you have woken up from the procedure, the catheter is removed and you're able to go home. Precautions when you have low-dose rate brachytherapy. You should avoid sitting close to pregnant women and children for up to 2 months after the treatment. Side effects, urinary problems. You will usually be given some medication to help improve the flow of urine in the days that follow the procedure. You will be given advice by your healthcare team about precautions you should take after having treatment, as these seeds are radioactive. Some effects of treatment include urinary and bowel problems and effects on erections. Your nurse and doctors will discuss these side effects in more detail if you are suitable for this treatment option.
In conclusion, we hope this information has been useful for you. If you wish to discuss any of these options further, please contact your local clinical nurse specialist. And please remember, you may not be suitable for all of these options. Thank you.